Shannon will be here in a minute. He just stepped out, maybe to get me coffee. All right. So on the schedule, we had anti-anginals, and you saw that we did the anti-anginal lecture the other day. I was actually ahead of schedule for once, and so I was actually pretty happy about that. We're going to spend a little bit of time today on the anti-arrhythmic drugs. So up until now, we've been talking about the pharmacology for cardiac diseases I would say, from an internal medicine standpoint. All right, so basically, no matter what discipline you go into in terms of your professional career, all of those drugs will be kind of your responsibility in some shape or form. The anti-arrhythmics, this is kind of where we delve into the more specialized cardiac disciplines. And so, there are specialists who deal with patients that have arrhythmias, and they're the ones responsible for prescribing the majority of these medications. So your job, if you were internal or family medicine, would be to understand how these work, and then basically relate some of the side effects and toxicities to what the patient is presenting. So you may not be the one prescribing these medications per se, but you'll definitely be the one kind of managing some of their therapies. And so what we decided to do was we decided to kind of combine the physiology of some of these receptors with the pharmacology to kind of put things in order from a very kind of fundamental, basic science perspective. And then as we go through, I usually have like a small mini summary presentation. I couldn't find it to post it with this. If not, I'll just write a new one. But to kind of maybe consolidate all these things, and we'll put that up together by the end of the week. Just because it's, there's not that many drugs here, but it is a little bit confusing. Okay? Learning objectives. And so just kind of some nomenclature. When we talk about arrhythmias, there's really two types that are used clinically, two distinctions. And one is supraventricular. And so basically these are arrhythmias that occur above the ventricle. So what's above the ventricle anatomically? The atrium, right? So another way of describing a supraventricular arrhythmia is an atrial arrhythmia. All right, one and the same. The other would be on the bottom portion of the heart, which would be the ventricular arrhythmias. And so these are arrhythmias that occur specifically in the ventricles. All right. Other descriptors in terms of cardiac arrhythmias include these two-word anomalies. So the first word is the anatomic location of where this cardiac abnormality takes place. So is it at the SA node? Is it at the AV node? Is it within the ventricular muscle fibers itself? And the second word describes the pace of the arrhythmia. So is it slow? Is it fast? Is it delayed? Is it fibrillating, or is it fluttering? Okay, so each of these, so you can get a supraventricular fibrillation, you can get a ventricular flutter, ventricular tachycardia, and so forth. Okay, and these are the things that you would see. So this is what these look like, and by now you guys have at least started to kind of examine the EKG. Of course, this one you'll recognize as normal rhythm. And I like this diagram. This is coming from Goodman and Gilman's Pharmacology Bible. I like this diagram because it gives you an example, and they're all on the same slide. So you can kind of compare the different EKG abnormalities based on the size and the frequency of some of these peaks. So here's an example of a premature ventricular beat, paroxysmal supraventricular tachycardia. This basically means this is a supraventricular tachycardia, or PSVT, that comes and goes. This is a fib, good example of that. Here's a flutter. Notice all the different P waves. A flutter with a one-to-one conduction. Here's a nice example of torsade de pointe. And of course, the very deadly ventricular fibrillation. So here's a nice kind of example summary of all the different EKG abnormalities. Understand that when we talk about some of the arrhythmias, we're going to start talking about the influx of ions. And that's pretty much kind of the impetus of this lecture, is looking at the movement of ions across some of these cells and what that means in terms of membrane potential. And so I kind of like this diagram. This really kind of shows the SA node specifically, looking at membrane potential over seconds. And so this tracing, this physiology tracing, is looking at the flow of these ions through the SA node. And this is what this looks like. So here's kind of that threshold in terms of minus 40 millivolts. Okay, and at this point now the sodium is leaking into these cells. Okay, and that is bringing this threshold to increase. And at this specific point, you've got these calcium channels beginning to open, and that gives way to the potassium channel opening, which increases the membrane potential into the positive. And then we've got a decrease after these potassium channels have opened, and the process repeats again. And so this tracing is very specific to the SA node. These fibers are inherently leaky to sodium, and this is the thing that, bless you, that kind of drives the self-excitation in terms of pacemaker activity. Okay. Likewise, here's the tracing for the ventricular muscle. The shape is a little bit different, looks like this. And notice the membrane potential starts a bit lower, goes down to minus 80 millivolts, and then goes up to plus 20. And here you see the first sodium channels begin to open. Okay, this is associated with phase 0. Potassium channels open as we proceed to phase 1. Get a slight decrease in membrane potential. This is when the calcium channels open more. This is responsible for kind of the prolonged repolarization. And then here, as we proceed to phase 3, now we've got the potassium channels involved. And then, of course, membrane potential plummets. And then we reach baseline. And then that process occurs again and again. And so this is kind of the tracing that you see for the ventricular muscles, and that shape is privy to ventricular muscle action potential. All right? And so in terms of action potentials, with each action potential, you've got the myocyte loses potassium and gains sodium. And this is maintained by that sodium-potassium ATPase pump, which is actually a viable molecular target when you look at how digoxin works. This increase in calcium around phase 0 favors the release of even more calcium from the sarcoplasmic reticulum. And that was the thing that was responsible for that increase in contractility that we associate with, the beta-1 receptor opening up the calcium. And then all that calcium influx is responsible for kind of maintaining that, or providing the stimulus for the cardiac recontractility. And of course, the refractoriness is always important, and we'll come back to that concept again and again. In terms of when we talk about refractoriness, it's really the amount of time that it takes for an excitable membrane to get ready for a second stimulus. Okay? Do you guys remember back when we talked about acetylcholinesterase inhibitors and acetylcholinesterase at the synapse, looking at the acetylcholine and the muscarinic receptor? We said that acetylcholine in very, very large doses can actually kind of change the refractory period of the receiving end of whatever cell has the muscarinic receptor. And so, there was a two-phase mechanistic approach to, really high amounts of acetylcholine offering or altering the refractory period of that cell. And this kind of basically reiterates that point. And so some of these drugs, and you can see this example here, here's a sodium channel blocker, minor changes in the refractory period, but other, more dramatic action potential prolonging drugs can actually shift the whole curve to the right. And that's really going to change the amount of time that muscle can be re-excited from a recent repolarization. Okay? And so clinically, what they've done is they've basically assigned the main antiarrhythmic agents into 4 main classes. The first class are the drugs that can block the sodium channel, okay? And the subclasses that are underneath it, there's 3, A, B, C, basically refer to what kind of an effect the sodium channel blocker has on the action potential. All right? The second group are sympathetic beta-1 antagonists, okay, which can act as antiarrhythmic drugs. The third group are drugs that prolong the effective refractory period, and these are potassium current altering drugs. And then finally, the fourth group of drugs are the calcium channel blockers. Okay, so all 4 of these drug classes can be and are used as antiarrhythmic medications. All right, and so there's a couple of generalities that you can kind of look at. If you look at the Vaughan-Williams classification, and kind of the different physiologic outcomes. All of these different drugs are kind of rated differently, and this is kind of where the ambiguity kind of exists. And so, the class 1A agents have physiologic effects on both the atrial muscle as well as the ventricular muscle. Okay, this would be in contrast to the class 1B agents, which primarily only affect the ventricular muscle. So right off the bat, if you've got a ventricular problem, either of these agents would probably be okay, right? But if you have an atrial problem, a class 1B agent really won't affect that that much. And of course, we can look at the efficacy. So how potent are these drugs? And so some of these are more potent than others. How toxic are these drugs? That's really kind of the key difference here. And so when we talk about therapeutic index, remember we talked about some drugs have a really wide therapeutic index? Most of these drugs have a relatively narrow therapeutic index. And that's because the efficacy and the toxicity are very close. Okay? One of the key annoying aspects of these drugs is that when inappropriately used, either due to a bad diagnosis or bad dosing schedule, the potential for arrhythmias can be increased. All right, and that's really problematic because here you've got a drug that you're trying to treat an arrhythmia, and when it's inappropriately used, can actually induce an arrhythmia. So then why bother treating, right? Exactly, that's probably what you're thinking. You know, these drugs do have their specific uses, but one of the easier ways to actually treat arrhythmias is to actually anatomically find the circuitry that's responsible for producing these arrhythmias, this faulty conduction pathway, identifying it electrophysiologically, and then ablating it. Okay, and there's different ways you can do that, but ablation essentially means identifying that false circuit, and then literally killing it. And so if you can't physically do that, or if it didn't work, or the patient maybe won't handle the surgery, these are the drugs that exist to kind of manage those patients. Okay. So we're gonna here's the outline. So we'll start with class 3 agents, and these are the potassium channel blockers. Then we'll go to class 1, 2, and 4. All right, and so there was a reason for this. Essentially, you know, Dr. Shannon thought that, you know, in terms of ease of explanation, we'll kind of provide them this way. We're in no composure to put the Vaughan-Williams classification in its correct order, so we're going to do it based on a logical sequence.